Thank you, Merrill. Those who came in a little late, what we're going to do is we're going to break into groups after the third lecture, and we're going to have 3 groups, and you can ask one-on-one, and if you can then drift to the other group to try to get insight from the other. And I think that's going to work better than if we just basically ask people to come up on something. So our second talk today is going to be given by Dr. Daly on careers in clinical microbiology, and she'll tell us about opportunities in that area.
So thanks so much, Arturo. And so I have way too many slides, and so there'll be many ways that you can get this information. Throughout the lecture, you'll get my email. I'll be more than happy to send that to you, and we're also going to post it on our website, so if it goes by too quickly, and then in the little discussion session, we'll have time there. Okay. So I'm going to do clinical microbiology. I've been a clinical microbiologist now for 25 years. It's like unbelievable. It's a wonderfully exciting and rewarding career because just like H1N1, the wonderful pathogens keep coming along and they really want you to help with that. So I'm located now at Primary Children's Medical Center in Salt Lake City, and I have these pictures of the 2007 Nobel Prize laureates. This is Mario Capecchi. I now live on 100, or actually I now work on 100 Mario Capecchi Drive because he's from the University of Utah. And this is Oliver Smitty's. I got my PhD, University of North Carolina at Chapel Hill, and he was from University of North Carolina. So please know that wherever you are, you can rub elbows with the greats. Okay, let's see if we can go forward. Okay, there we go. So we're going to talk about in the beginning and kind of follow my career so you'll get an idea of how one way to do it is, but I'll try to explain a few others. A little bit about the postdoc programs, but I want you to get most of that information off the websites, and then my job experience. So I started at a little tiny university, 3,000 liberal arts school in DeLand, Florida, Stetson University, with a degree in biology. Then I went to the University of North Carolina at Chapel Hill, got a master's degree and a PhD with a wonderful guy, Fred Sparling, who is an infectious disease physician that's getting very close to retirement now. But Fred had several people in his lab, and one was doing a Clin Micro postdoc, and that's one where you have to do a matching program. So I got interested in that, interviewed, and matched at the University of Utah. And after I trained 2 years in a Clin Mic postdoc, I became an assistant professor. So I'm an academic clinical microbiologist, but my lab is Primary Children's Medical Center. And why not do clinical microbiology in a pediatric institution where you have the highest birth rate in the nation? So this is a poll. We have a wonderful connection called the Clin Micronet that the American Society for Microbiology provides for us. And we did a really quick poll on what people's backgrounds were. As you see here, there's a whole bunch of various BS backgrounds and lots of MS backgrounds and several PhD backgrounds. So a clinical microbiologist can come from a number of areas, and then you can also get into the profession in a number of ways. One of the easiest ways is to do this CPAP, Committee on Postgraduate Education Program postdoc fellow. If you're a PhD, it'll take you 2 years. If you're an MD, 1 to 2 years. And you train. You learn how to do bacteria and fungus and parasites and virology, susceptibility testing and molecular diagnostics. You do management, safety, epidemiology, and public health. And then you look at an infectious disease. If you're a PhD scientist, you don't know that area, so one of those years you spend all your time trying to learn the clinical connection. So you end up as a person that does discovery, diagnosis, and treatment and prevention of infection and immune-mediated diseases. You direct a lab. I have 25 med techs in my lab. You combat emerging antibiotic resistance, so methicillin staph aureus is a big deal. You look at pandemics, H1N1. I do the virology lab at Primary Children's, so I was up to my ears in that. And you respond to bioterrorism events. This is on the website, the various places that you can train if you want to go for the 2-year training. I'm part of the University of Utah training program, so I can tell you a little bit more about that, and you can actually major in immunology. This is the American Society for Microbiology website, and if you go to Academy and come down here, you can actually see the postdoctoral training area, and there are various categories where on the website you can see detailed information and you can actually see forms and things that you can produce. Now, I do want to say in July this website is going to change and it'll be a lot user-friendly, so we're looking forward to that. So back to the job experience. Day to day, you're involved in clinical cases. And clinical cases in bacteria means you look at agar plates, and for example, aureus is a really old pathogen, but lugdunensis is a brand new one. And we do little spot tests like catalase and coagulase and all of these kinds of things to do identifications. So with lugdunensis, we've got a new white colony and it's slightly beta hemolytic and it's catalase positive and it's slide coag negative and 2-cloag negative and it does a PYR. And basically that's what you're doing, identifications and susceptibilities of the pathogens in the specimens. And you learn new testing. For example, this is a brand new thing in order to identify lugdunensis. And then you're very, very interested about susceptibility testing. And so this would be a test called the Bauer-Kirby, and it's an agar plate where you spread the organism over and then you've got drug on the plate, and if it's susceptible you usually get a huge zone, and if it's not you get a small zone. So you're very interested in your patient isolate and whether it's susceptible or resistant. Now, the other neat thing about the career is the American Society for Microbiology takes clinical microbiologists and gives us many groups to work with. And one of the groups was this ASM benchmarking group that has provided information on the website. This is mostly directed to medical technologists, which are the 4-year degree people, but it will give you a flavor of what we do in Clin Micro. So you could work at a non-profit hospital or a for-profit hospital or a network like I do. I have 21 hospitals in my network, or a university medical center or a community reference, a VA or other. And you do, as we discussed, bacteria, immunology, fungus, parasites, virology, acid-fast bacilli, and molecular ID. In clinical micro, we have hardly any automation. The only two things are the blood cultures and susceptibility testing. Everything else, it takes your brain to figure out what's going on with that patient isolate. And it's known as the labor-intensive area, so your technologist will be doing cystic fibrosis cultures. There are 4 or 5 pathogens there that are becoming resistant to many drugs. You'll do anaerobic culture, you'll do homebrew molecular tests. Many of your current PhDs are doing PCRs, and we do a lot of homebrew. You have to work with more than one computer system, MISIS or SunQuest, and you train all the time, even in the community setting. So these are just some percentages, and you'll notice here again, you do a lot of training even if you're in a community location. So you would be, as a PhD with the 2-year training, a lab director, and many labs, I have 25 people, have managers, I have 2 supervisors, about 10 medical technologists. There are some 2-year degreed people, and then there are many lab aides to get your specimens worked with. And I show you this because every state has different requirements for lab directors, so if you think you've got a lock on that information, you don't. They all are different, and you have to go to the state information to figure out if you qualify for those states. So I'm an academic person. I'm a professor of pathology, and here is my email, judy.daly@imail.org. But my lab is a pediatric lab that's staffed by the University of Utah. So pediatrics and pathology, radiology are University of Utah. So again, it's kind of neat to look at the old days. 35 beds in 1922 for primary children's, 70 beds in 1952, and I began in 1987. So this hospital is where I started, and now 270 beds. And in Utah, we have a lot of land and hardly any people. We serve 5 states, or in the West. We are the 12th largest of approximately 50 freestanding children's hospital. We have high acuity. We're the only pediatric institution, so we have all the trauma ones and all the infections. We see 70% of the 21 hospitals of their infections. And then our guy comes to the Hill and testifies because we have the lowest charge per case, which is something that's a big deal these days, Brent James. Okay, so what I do from the professor side is fun stuff like update courses. We go to Jackson, Wyoming in the summer and Park City in the winter and teach a week course, and that's fun because you get to see your colleagues. But we do a lot of path residents and pediatric resident training, med students, med techs, and we do a lot of mentoring. So you are able to publish. This is just a little list of the 2008 publications that are on my CV, and they're all varied. You can, I ended up with like 8 publications for 2008, and some are tularemia, some are other things like vesicular lesions, some are group B strep, which is a tremendous pathogen. So they're all over the map because you do all of that training. And then as far as reviews, chapters, and special publications, you work with organizations like the American Society for Microbiology. Currently, I'm working with the Clinical Laboratory Standards Institute, so you're part of publications that have to do with the profession, and so 3 from last year. And then these are presentations at meetings, and they're again about 12, so they're just before you do your publications. But because, for example, Primary Children's has all those babies being born, we have 14 infectious disease physicians, and they all want a project. So publishing is very easy. Okay. So we do lab management, and that is actually trained. So you get 6 months of how to manage a laboratory. One of the ways to keep your laboratory open is accreditation. So you have a checklist that you need to make sure you do a lot of quality control, and we use the College of American Pathology. You do a lot of teaching, you do projects, and you can have research grants. Our previous speaker talked to us about technology transfer. This grant, where I am a co-investigator, about a $3 million grant, you'll see a little bit later, it has to do with Idaho Technologies and a little PCR test that we're doing on patient specimens. And then the fun part, too, is being part of your professional organizations. Clinical microbiologists have the American Society for Microbiology and a number of other organizations where you can give back, like this lecture today, and I was secretary of this society for a number of years. It's just very, very enjoyable. Okay, now I'll talk for a few minutes about 2 projects that was not my idea in the beginning before I started doing this, but became more and more interesting as we went along. And so one was, in the year 2000, we started doing direct fluorescent antibody testing, so This is a monoclonal antibody that you put on a patient specimen and you detect 7 respiratory viruses. And every 2 weeks we would email it out to the people in that 21 hospital system. Now we have this big deal enterprise data warehouse that I'm going to talk to you about, and at any time someone can go to the website and within an hour see what is circulating in the state of Utah. So you collaborate with a lot of people, and just like our previous speaker, you learn about collaboration. In fact, when we teach medical students these days, we talk about collaboration. You do that often. So this huge group of people collaborated on this project, and again, it was rolled out in Intermountain Healthcare, which has the 21 hospitals, of which mine is one. And again, we have one enterprise data warehouse, and it's this huge thing that you can do SQL language to get your data out and figure out what's circulating. And so the scenario is you're a doctor working in an emergency room or an urgent care or an after-hours clinic, of which we have at least 100. A mother brings her 16-year-old son, Billy, for acute onset of fever and cough. And what does Billy have? Is anything going around? What can we do about it? What's going to happen to Billy? Is there a risk to my other children? So what infects Billy matters, because is it bacterial? Is it viral? So the different interventions are critical. Antiviral medications are different than systemic steroids. The treatment and over-the-counter is for symptoms, you know? And so it changes, forecasting the natural history, estimating the risk for adverse outcomes and complications. So the doc in the box is there trying to figure out what Billy has, and you know, you've got your signs and symptoms, your epidemiology, your physical exam. They know about infectious disease, and they might have a diagnostic test, maybe not. But what we give them is the knowledge of the local incidence of various infectious disease. So this is pathogen-oriented. So the objective of this was to take to the front line of acute care providers, take it from just clinical practice without knowledge of what's circulating to what actually is. And how does a clinician get their information? News media, their own experience, bulletins from the health department, internet sources, or population-based data. And again, R1 Enterprise Data Warehouse can deliver all these types of data, all this type of information, and distribute it all these ways. So there's a whole bunch of science that goes into getting what we need, which is pathogen-specific, population-based data delivery. And so this little project started, like I said, in 2000 with what we were doing email-wise on the respiratory viruses. And now, every hour, they can see this is the syndromic effects. So imagine that yellow is respiratory syncytial virus, and the purple is influenza A, and H1N1 is the black. You can actually show them what's out there circulating. And so we really don't care exactly what the data warehouse is involved with, but you can take all these facts and you can put out a report, put out something on the patient's chart, or do this marvelous Google thing where if you want to know what's circulating in what zip code or what county, you can find that out. And here we had a cryptosporidium outbreak, so we had to shut down all the water fountains because little kids were playing in the water and basically they were spraying cryptosporidium all over the place. But we would not have known that and been able to get the word out had we not had this hourly update session. So that is just one example of what we were doing there, and it wasn't a project I started, but it certainly is tremendously relevant to the patients of Utah. And now we are going to go on and see how we can develop matrix for this population-based practice and look at optimal data delivery and optimal information dissemination and how it integrates into the workflow. So that's just one example of being a service clinical microbiologist, because my appointment is 80% service, 20% research. And this will be another example. And our first lecturer gave us the information about this. Idaho Technologies is a company that's developed a PCR in a package, and it's lovely because you put the specimen in and then you get an answer, and it's so wonderful. And we are helping to develop various amounts of this test. So right now it's called the film array. It's an automated nested multiplex PCR. And so over the years, your Tox Dollars at Work has helped develop this test. In fact, when we had the 2002 Olympics, we were sniffing the air and figuring out if tularemia had been sprayed around there, or plague or anything, because we were all very worried about that. But it's light cycler technology that has now been put into an array system. So it's a high-order, real-time, nested multiplex PCR where you have sample preparation, PCR, and post-PCR analysis all in one little package. It's less than 60 minutes, and it's a little tiny system, which makes it way nice. So you have these beads that are milling that liberate the nucleic acids. Then there's a magnetic bead, nucleic acid extraction, or reverse transcriptase, the nested multiplex PCR, and you get your product. So right here you have freeze-dried reagents up here of the sample that go into the cell lysis. Then you get nucleic acid purification, and this is all going through this pouch down here pneumatically. So you've added the sample and you walk away, and this array then tells you what you're actually dealing with. And the first testing we did was respiratory viruses, so we added SARS and all kinds of exciting things, and human metapneumovirus. And then these actual lines show your melts, and those are different organisms. So we did our testing at Primary Children's, and we learned new things like a dual infection of respiratory syncytial virus and human rhinovirus, or a dual infection, which is, or a triple infection with bocavirus. And our infectious disease guys really didn't know what to do about that, but now we know that one virus helps one infection get established if you do have more than one. And of course, the PCRs were a little bit better than our direct fluorescent antibodies, and that data came out. And then, in clinical microbiology, you're always interested in various platforms, and there's another platform called Luminex, which I'm sure is displayed at this meeting. So there was a comparison between the platform we were developing and this new platform. And the important parts to clinical microbiologists are that this platform has multiple samples, which you need to find a way to load 50 samples. Because when H1N1 showed up, each cycle we had at least 50 samples every 2 hours. And then the closed system part is critical. The test we were developing is completely closed. This platform is not. And it's very labor intensive. And then when your Tax Dollars at Work develop these, they say, we want the test to cost $12. Well, $396 is not $12. So you have to work hard with that part of it. So those are two projects that are actively going on in a pediatric institution in Utah. This is a brochure that's put out by the Academy. So if you go to that American Society for Microbiology website and look up Academy, you can find this brochure, and it will tell you much more about clinical microbiology. But I want to remind you that through my 25 years of doing clinical microbiology, as the pathogens come up, that's something that you work on. So if you have a pertussis outbreak, then you work on that and look at new testing or new epidemiology, or if you have any of these others, enterohemorrhagic E. coli is a big deal in Utah. We spend a lot of time trying to make sure that we get that very serious infection right. So the excitement of clinical microbiology is always there. There's something new and exciting for you to be working on. And when I started 25 years ago, we talked about, well, everything in the next 2 years is going to be 100% PCR, and we will not be looking at little dots on plates. And I tell you, today we're still looking at little dots on plates because there's a lot of things that play into the advancement of science. This article suggests that maybe when you get up in the morning and you pee into the toilet, by the time you're ready to leave, you have a diagnosis of what's going on with you. And so, you know, completely remove yourself from having a clinical microbiology lab. Somehow, I doubt that will be the case. So in a pediatric setting where 70% of all infectious disease is seen, it's been a pretty exciting time. And so I would say if you're going to be a clinical microbiologist, you might want to be a pediatric clinical microbiologist. Thank you.